Admiral Michael Weahkee is an amazing gentleman whose service began in the U.S. Air Force. He's an enrolled member of the Sunni tribe with personal ties to the Indian Health Services, which we kind of refer to and is referred to as IHS. He served as the 10th director of IHS, overseeing healthcare for 2.6 million American Indians and Alaska Natives. He was previously the principal deputy director of IHS and CEO of the Phoenix Indian Medical Center. Rear Admiral Weahkee's career began as a military public health specialist in the U.S. Air Force. He holds advanced degrees in health service administration and business administration from Arizona State University. His roles at IHS headquarters include executive officer, director of management and policy, and deputy director for personnel. He has received multiple health honors and awards for his contribution, and his leadership has improved healthcare services and operations for Indigenous communities. He has recently served in an advisory capacity to ASU's College of Health Solutions, which helped Homebase formalize a partnership with the college to offer Warrior Health and Fitness program there. Please give a warm welcome to Admiral Weahkee. And if I could, I apologize. If you don't write it down, you don't do it. I was neglectful in not also mentioning the fact he's joined today by his amazing wife, Rose Weahkee, Dr. Weahkee, who is a psychologist and treats our veterans and has worked with the Indian health system for many years. And so welcome, Dr. Weahkee.
Well, good afternoon, everyone, and thank you for allowing me to join you today to tell you a little bit about the work that we do at the Indian Health Service. We always like to start with the mission statement, so let me take us there. We like to refer to our mission statement as being holistic in nature, to raise the physical, mental, social, and spiritual health of American Indians and Alaska Natives to the highest level. And as Jack noted in my bio, which needs an update apparently, we service 2.8 million American Indians and Alaska Natives now, as opposed to a few years ago when I was running the show. So somebody's having babies out there, it feels like. Let me first start with some history on the agency. The Indian Health Service was formally established back in 1955, and the provision of health services to members of federally recognized tribes grew out of the special government-to-government relationship that exists between the individual sovereign Indian tribes across our country and the U.S. federal government. We can trace the history of our agency back to the creation of our nation, when Army doctors would take care of the Indians that were residing right outside of the Army posts, mainly to ensure that the transmission of illness to the service members was mitigated. Over time, responsibility of the care and treatment of Indians transitioned from the War Department over to the Department of Interior, and then onto the Department of Health, Education, and Welfare, which is now known as the Department of Health and Human Services. The Snyder Act of 1921 and the permanent reauthorization of the Indian Healthcare Improvement Act provides specific legislative authority for Congress to appropriate funds specifically for healthcare of Native people, and numerous other laws, court cases, and executive orders have reaffirmed these relationships over the years. I also want to underscore that the U.S. government's commitment to providing access to health care, as established in treaties and in law, is the responsibility of the entire U.S. federal government. The IHS is the main embodiment of that obligation, but all of our programs, every part of the U.S. federal government is also responsible and has a role to play. At the IHS, we provide comprehensive primary health care and disease prevention services to the approximately 2.8 million American Indian and Alaska Natives from 574 individual federally recognized tribes through a network of over 605 hospitals, health centers, and health stations located all over the country. And I like to tell people when you meet a tribe, you meet an individual tribe, or you work with an individual tribe, that you've met one of those 574. There may be some generalities when you work with Pueblos, or you work with Lakota, or you work with Apaches, but each and every one of those individual tribes have their own governments, have their own religions, have their own language, and that's an important aspect so that they're not lumped as just an ethnic or a racial group, but these are also independent nations unto themselves. The IHS federal healthcare staff consists of more than 15,000 employees nationwide, including healthcare providers like you'd see in any other hospital, physicians, nurses, pharmacists, dietitians, optometrists. We also provide a comprehensive environmental health program that includes injury prevention, safe water, sewer and solid waste, sanitation facilities construction throughout Indian country. We also have a significant imprint in community health with both public health nurses, community health representatives, and up in Alaska, a program which is currently being replicated here in the lower 48, the Community Health Aid Program, which includes community health aid proper, behavioral health aides, and dental health aides. So here's a geographic representation of our agency. We are broken up into 12 area offices and serve a variety of different populations, both in rural and urban areas across 37 different states. Our patients sometimes travel great distances to get to the nearest facility, especially in states like Alaska, where many of the villages are only accessible by either airplane or by dog sled or snowmobile. Some of the facilities in our health systems are in large metropolitan areas like in Phoenix, Los Angeles, Sacramento, Oklahoma City, and others are in some of the most rural and remote parts that you'll find in our country, like north of the Arctic Circle up in Barrow, Alaska, or at the bottom of the Grand Canyon in the Supai Village. Some of the facilities listed here are operated directly by the Indian Health Service, the federal government, while others are operated directly by tribes and tribal organizations. Under the Indian Self-Determination and Education Assistance Act, tribes have the option of exercising their right to self-determination by assuming the control and management of their own programs that were previously administered by the federal government. Since 1992, the IHS has entered into agreements with tribes and tribal organizations to plan, conduct, and administer programs under this act. And as we stand today, more than 65% of the Indian Health Service appropriation is managed directly by tribes. The IHS also provides funding to 41 urban Indian-centered healthcare organizations that care for American Indian and Alaska Native partners in metropolitan areas like Baltimore, Denver, San Francisco, and right here in Boston. In addition to including almost $7 billion for IHS in fiscal year 2023, the Consolidated Appropriations Act of 2023 provided the agency with advanced appropriations for the very first time. This change will provide critically needed protection from budgetary uncertainty to the Indian health system of care, and will align IHS with other federal health care programs like the VA and the Department of Defense. It's also a direct result of years of advocacy from tribal and urban Indian organization leaders who have long highlighted the need for a more stable and predictable funding stream for the Indian Health Service. Advanced appropriations are necessary to ensure continued access to critical healthcare services for American Indians and Alaska Natives. And this predictable funding will allow us to disperse funding out to our partners in tribes and urban organizations sooner so that they can plan for and coordinate care and improve health outcomes for our patients. The Indian Health Service has historically faced funding deficiencies that impact our ability to carry out our mission. The federal government spends less per patient on healthcare for American Indians and Alaska Natives throughout the Indian Health Service than it spends in any other federal healthcare program. In 2021, the actual IHS spending per user was $4,140. And by comparison, Medicaid spent about $8,900 per patient, and the Veterans Health Administration spent $12,223 per patient. The data we have for Medicare for 2020 identifies that Medicare spent $15,763 per beneficiary. So you can see a significant funding gap when it comes to per patient spending in our system. So next, I'd like to talk a little bit about health disparities in American Indian and Alaska Native communities. This slide has a lot of information and some recent quotes. This was actually taken from our congressional budget justification that's going forward this year. American Indians and Alaska Natives born today have a life expectancy that is almost 10 years less than the U.S. general population. American Indian and Alaska Native people have long experienced lower life expectancy and lower health status when compared with other Indian Americans. And we believe this to be linked with social determinants of health. We have many different challenges throughout Indian country, as you might expect. And we are tracking closely on the transition of the use of social drivers of health or social influencers of health in place of social determinants of health. And just last month, or could have been earlier this month, there was a presentation made to the World Health Organization on indigenous determinants of health. So we'll be watching and tracking that body of work as well as we move forward. Lastly, American Indians and Alaska Natives continue to die at higher rates than other Americans in many different categories, including chronic liver disease and cirrhosis, diabetes, unintentional injuries, assault or homicide, intentional self-harm or suicide, chronic lower respiratory diseases, and multiple forms of cancer. These disparities were made even more evident during the COVID-19 pandemic, as American Indians and Alaska Natives consistently suffer from higher COVID-19 incidence, hospitalization, and mortality than any other racial or ethnic group in the United States. COVID-19 also revealed many health and infrastructure disparities throughout Indian country. For example, tribal communities did not have the capacity to conduct public health department activities during the ongoing pandemic. As noted on an earlier slide, diabetes is one of the medical conditions that's been associated with the risk of complications in COVID-19 cases. And Native people have the highest prevalence of diabetes of any U.S. racial or ethnic group. Back in the year 1997, Congress established the Special Diabetes Program for Indians to provide grants for diabetes treatment and prevention services to IHS tribal and urban Indian programs across the country. And while American Indians and Alaska Natives continue to experience higher rates of diabetes than other ethnic groups, the recent SDPI program for Indians 2020 report to Congress highlights the program's ongoing and outstanding contributions to improvements in diabetes care and health outcomes for American Indians and Alaska Natives. This includes, for the very first time ever, a decrease in diabetes prevalence in Native adults, which has decreased consistently over the last 4 years from 15.4% in 2013 down to 14.6% in the year 2017. We have seen and we are tracking on the impact of COVID and the service interruption for primary care in our Native populations, and we do expect that this number may rise again as a result, but it is something that we are watching very closely. SDPI grant program sites are successfully implementing evidence-based and community-driven strategies to prevent and treat diabetes, and we look forward to seeing the results of their continued efforts. One of the best practices that we've found through this program is that community-driven ability to create programs that are responsive to your individualized community needs. So whether that may be a fitness center or a place for your youth to gather or nutrition education, each community can determine for themselves what they think is going to be most helpful for their tribal members. We just recently announced a few months ago the decisions for the $147 million that was authorized by Congress for the SDPI program, and we're expanding the number of grantees from 275 up to 302 in this next grant cycle. So speaking to this audience, I feel like you all probably can educate us a lot more on being trauma-informed, but the Indian Health Service has made a significant effort to ensure that all of our programming is trauma-informed. I started here with a definition of trauma, but you all can give me many more definitions. But when we speak specifically to Indian country and the traumas that we face, the relationship between our individual tribes and the U.S. federal government has been tumultuous over time, and we have previously approved federal policy like the termination policy or the relocation policy, various attempts to integrate American Indian populations into general population by removing individuals from their reservation communities, forcing children into boarding schools, providing incentives for people to move into cities and to take jobs, had interruptions. It created interruptions in our family structures, and the traumas associated with lost language, lost religion, lost culture continue to impact our communities to this day and our family structures. Some additional top challenges to take into consideration. As noted, the funding picture is not pretty for our agency, and as a result, those 605 facilities that I noted, many of them are very much aging. So the average age of our hospitals and health clinics is 42 years old, and when you compare that to healthcare industry in general, where most facilities are 10 to 11 years old, you can see it becomes increasingly difficult to meet accreditation standards and to ensure life safety and environment of care standards are met. We also have an electronic health record, which is very much old, and the GAO has identified that it's one of the top 10 legacy systems in federal government that needs to be replaced. So we are in the process of an EHR modernization effort, tracking very closely what the VA is doing with Cerner Genesis and some of our other sister agencies across government, like the Coast Guard and others have kind of followed suit with that same EHR. So we will be tracking and selecting a different platform here for ourselves soon. We have provider vacancy rates historically at 28% overall professions. If you look at specific provider types like physicians, advanced practice nurses, physician assistants, those numbers climb into the 30s, 35 to 40%. So we are constantly looking for different strategies to recruit and retain professionals across all of our health professions. And then being part of federal government, we get the fun role or opportunity, I guess you'd say, of being reviewed internally by government watchdogs, Office of Inspector General at HHS, the Government Accountability Office, who does watchdog activities for Congress, and of course, our own accreditation surveyors coming in from Joint Commission or AAAHC. So career opportunities, it wouldn't be a good presentation if I didn't try and influence a few folks over. IHS does have a scholarship. Or tell your friends. Scholarship and loan repayment program. So Congress has blessed us with that. It's similar to the National Health Service Corps program run through HRSA. Ours is really just specific to Indian Health Service. locations once you graduate. So I've got a website there listed. I put our highest vacancy rate professions up there on the screen. And our programs support not only our federal sites, but also once somebody graduates, if they want to go to work for a tribe directly, or if they want to go to work for an urban Indian health program, they have those options as well. So we are sure to make that comprehensive to our entire system of care. I also put on there some hyperlinks to more information. If you do have a student or others in your families or friend circle that may be interested, please send them our way. And a little bit about the U.S. Public Health Service Commission Corps. The uniform that I'm wearing is the same uniform that the U.S. Surgeon General wears. And just to provide a little bit of history, for more than 225 years now, men and women have served on the front lines of our nation's public health in what's called the Commission Corps, the U.S. Public Health Service. And at the Indian Health Service, we employ more Commission Corps officers than any other agency in the federal government. Currently, Commission Corps officers are involved in healthcare delivery to underserved and vulnerable populations, like at the IHS, in disease control and prevention activities, such as at the Centers for Disease Control and Prevention. They're doing biomedical research at NIH, food and drug regulation at FDA, mental health and substance abuse services at SAMHSA, and response efforts for natural and man-made disasters as an essential component of the largest public health program in the world. The Commission Corps continues to fulfill its mission to protect, promote, and advance the health and safety of our nation. And the work of the Public Health Service is essential to the IHS mission as we work together to deliver health care for American Indian and Alaska Native communities across the country. I did want to point out, in addition to the information here on this slide, there at the bottom, there is a brand new PBS documentary that was just released about 2 months ago called The Invisible Corps. And it's right about an hour in length, but it provides a very good history of the U.S. Public Health Service and talks about the work that we've done over the years, fighting Zika, Ebola, and the history of the Corps, of course. So partnerships, what we're here to talk about today, in collaboration efforts. We're working to address many of the challenges throughout Indian country through partnerships. And we do work closely with the Veterans Health Administration, which I'll talk about more in depth here. We have a interagency memorandum of understanding between our two agencies that aims to provide eligible American Indian and Alaska Native veterans with greater access to care closer to their homes, to promote cultural competence and quality health care, and to focus on increasing care coordination, collaboration, and resource sharing between our two agencies. We're committed to working with partners like Johns Hopkins Center for American Indian Health, and our partnership with them is extended for the last 30 years. When we signed an MOU with them and their Center for American Indian Health, and they really have a focus area in workforce development, and especially in community health workforce development. So they provide a lot of educational opportunities in allied health care, health sciences, and for both graduate and doctoral level students. They do that specialty training for community health paraprofessionals, like those community health aides that I mentioned, and community health representatives. And our continued work in partnership with tribal and urban communities to disseminate and implement evidence-based practices and promote behavioral and mental health well-being activities. We have many other federal and national partners, including Home Base, which I'm very proud to be leading the efforts on behalf of the agency to further expand those partnerships into the Southwest, and bringing more of our sister programs from our tribal and urban entities into the conversation, and making sure that people are aware of the tremendous services that you all provide. We also have a long-standing partnership with MGH for residency rotations. mainly at the Rosebud Indian Hospital in Mission, South Dakota. But we are looking to expand that opportunity throughout other parts of our healthcare system as well. So very much appreciate all the work that you all do on a daily basis. So let me dig a little more deep into the VHA partnership and talk about some recent activities. We have had an agreement in place with the VA stretching all the way back to the 90s, and we've renewed it a few times over the years, most recently in 2021. And at any time that we roll out a new program that's going to have a significant impact on our tribes and the patients that we serve, we engage in what's called tribal consultation. So we sit down and we meet with tribes and ask them, okay, we're looking at working in this space. What are your priorities? What are your challenges? What's working well? How should we best dedicate this resource towards that need? And so we entered into consultation with the tribes to develop the goals and objectives for the latest iteration of this MOU. And 3 items really came out strong. Communication, improving communication, not only between our 2 agencies, but with all the tribes and urban Indian programs that we serve, to better collaborate across the whole spectrum of care. The umbrella MOU is pretty comprehensive in terms of what we can pursue, and that we should be doing more of it. And then to ensure that at every level, both the local, the regional, and the national level, that we are taking tribal consultation and urban confer into account and not doing things to people, but doing things with people. So that's an important aspect of all the work that we do within the Indian Health Service. Here are the 4 mutual goals that were identified in partnership with tribes to increase access and improve quality of care and services for our veterans, to ensure enrollment and seamless navigation for veterans in both the VHA and IHS, to facilitate the integration of VHA, IHS health information technology systems. So really Congress is driving us to make sure that we're interoperable, and then to also improve access through resource sharing. There are various objectives beneath these 4 goals are listed here. And again, these were developed in partnership with the tribes. So you'll have this slide available to you to identify how we can leverage both the resources of the Indian Health Service and the VA to move forward on these various objectives. Most recently, we've been engaged in a White House initiative. The White House Council on Native American Affairs has identified homelessness as one of the important social determinants that are impacting Indian country, especially with our Native veterans. And the VHA's Homeless Programs Office has been leading the effort under Secretary McDonough, and Secretary Becerra, who's the HHS Secretary, is his co-chair, and will be taking the reins here within the next couple of months on this specific initiative. But we are looking at partnering across our systems of care, at least initially focused on 5 specific geographic locations. Those are listed here, and we've got the various VHA and Indian Health Service points of contact, as well as our urban Indian organization POCs. So Seattle, Albuquerque, Phoenix, Los Angeles, and Alaska. There's also a White House-led homelessness initiative that is focused on these same geographies, but they've extended to the entire state of California as well. And my wife can correct me if I'm wrong, but I believe we have 8 urban Indian organizations throughout the state of California and in different parts of that state. So this will be a very large initiative that we're focused on making sure that our Native veterans know the resources that are available to them. We have HUD at the table so that we can talk about leveraging their voucher programs and other housing programming. And then we're making sure that they're getting the health care that they need where they live and sheltering them. Also, hot off the press, we've released a interactive map application. It's on the Indian Health Service website at www.ihs.gov. And this provides a way for people to find services close to where they live, whether that be IHS or through the Veterans Health Administration. They can look at where they're at or where their friend may be at or their family member and link them to services where they live. So we're excited about that, and it was a long time coming, and happy that it's now available for our Native veterans and others. So the future of the Indian Health Service, we will continue to carry out the federal government's commitment and responsibilities for providing healthcare services for American Indians and Alaska Natives, and look forward to partnering with you to doing that to the very best of our ability. So I want to thank you for your time today and the opportunity to provide any answers to any questions that you may have about the Indian Health System of Care. And I know we've got several others from our system in the room that can help if I get stumped on any aspect. So look forward to leveraging the expertise that we have here available to us. With that, I'll conclude my presentation and open it up for questions. Yes, sir. Right, right. And for those who are joining us online, the question is about broadband access in rural and remote locations. We have been fortunate to be able to participate in some of the recent funding that came about under some of the COVID-related acts. But not all communities, of course, have been able to leverage those resources. So definitely broadband access continues to be a challenge for us in many of our locations. We are growing that capacity, but we're definitely behind the rest of the country. So it is a significant barrier to telehealth and reaching those communities through different modalities. And that struggle will continue until we figure out other options. I know that there are some innovative ways that companies have been reaching third world countries with broadband, and so we may be able to access something like that to continue to improve access throughout Indian country as well. Others? Yeah, well, I can start right at home. My own father, my older brother, both passed away from COVID. But in more general terms, American Indians and Alaska Natives, we were already struggling with healthcare conditions with high rates of diabetes, obesity, overweight. Just an example, taking it back home, my father was fighting cancer at the same time he caught COVID, and so it stripped his immune system, and he couldn't build the antibodies to fight COVID. My older brother had heart stents put in. He was morbidly obese, and so between the obesity, the cancer, and the heart conditions, when he got COVID, it was a struggle. But because we have so many American Indians and Alaska Natives living with significant health concerns, when something like a pandemic comes, we are disproportionately impacted. And fortunate to have the attention of Congress and the presidency in this last round to get resources into our communities as quickly as we did. I think it would have been much worse had they not been prioritized and treated as a separate jurisdiction at the same level as a state or a territorial government. Yes, sir.
Can you
So-
speak a little bit about is there integration between native healing practices and Western medicine as part of the Indian Health Service?
Great. Thank you for bringing that aspect up. So that is something that we hold dearly, is that balance of Western medicine and traditional Indian health practices. Many of our agency policies, both at the national level and at the facility level, specifically speak to this. And we create the space, we honor it, we we credential in a way traditional practitioners to come into our facilities and provide services, whether a patient wants to be cleansed through smudging, or if they want to participate in a sweat lodge ceremony, a crystal ceremony, whatever they want and believe is going to help with their healthcare condition, we are supportive of. And we do things like, if you're going to be smoking, distributing smoke from cedar or sage or sweetgrass in a healthcare facility, we shut down the sprinkler system so we don't have any rain coming at the same time. But we very much respect, promote traditional health. We make sure that all of our providers are provided with cultural competency training in advance so that they understand the importance of this to individualized care. Many of our sites also have sweat lodges or spaces on site where people can practice their traditional Indian health ceremonies as well. Other questions?
Admiral, clearly in many communities, geography is a challenge. Can you talk about how, and we know that reaching out for mental health care can also be a challenge. So how have communities, if you could provide some examples of some maybe innovations about how do you reach individuals who may need help and how those communities support one another when it comes to their own mental health care?
Yeah. Well, when I think to our traditional outreach methods, I think that as an agency and as our tribal organizations and urban Indian organizations have used as well, we show up where people are. So community events like powwows and big times or feast days, we try to be there and share information, be accessible and visible. So, that is one way historically. I think the integration of behavioral health into primary care and vice versa, integration of primary care into the behavioral health setting is an important aspect so that we catch people when they're there. We have worked hard as an organization to be trauma informed so that even in the primary care clinic, people are asking about past traumas that may have been experienced, and then using that information to get them into the appropriate level of care needed. So I think these are some initial thoughts that come to mind. Happy any of our partner organizations that may have other thoughts on how we bring folks into mental health care. Anything I missed? Anything you want to amplify? Yes.
So hi, my name is Nicole, and I am the site director for Native American Lifelines, which is an urban Indian center of Boston. A lot of our clients want Native providers, and so non-Native sometimes think that that's, a slight against them, and that's not it at all. It's just that when you have a Native provider, there's already a level of understanding, and you don't have to use the first 6 to 10 sessions just getting to know that person. And so we have found that a lot of people are stuck in their training, or there's a lot more challenges. As natives, a lot of times we are older when we go to college, and so we have families, and if we have to move away, that's another challenge. And moving to urban centers is very different than when you live in your tribal territory. And so there's a lot, it's like, I call it the perfect storm right now, because there are a lot of people who need the help, but we don't have the Native providers for them. And so as urban centers, as tribal centers, and IHS clinics, how can we work together to share the help? And still, by doing some of that work, we still are at a deficit. And so I think that we as Native people, we need non-Natives to be understanding and be willing to learn about our culture and then start to work with us, rather than what you may have been taught in school or what you might see on TV. We're all very different. East Coast to West Coast, we're all very different, very, very different. And so even as a Native person in a land that's not my own, I have to earn the respect of the people here, of the tribes here. And so just knowing how to be respectful and that will open the door for you to be able to help us.
Thank you for that.
I just had a quick question. Are you aware of any programs where you have partnership fellowships with organizations? So for example, if home base was looking to do something like that, where potentially there's a swap where, whether it's 3 months, 6 months, where a provider from one of your communities could come up here and a provider from home base could go work in that community for 3, 6 months or something like that. Are there programs like that available?
Yeah, there's not an ongoing program, but we have entered into arrangements such as that in the past. One example that's coming to mind, we had a provider from Indian Health Service go for a year to the Institute for Healthcare Improvement and be trained and bring that information back to the agency. And conversely, we had IHI physicians and other, quality improvement advisors come to the Indian Health Service. Doug Eby, who's in the South Central Foundation up in Alaska, is a great example of that. He's now providing care and treatment in a clinic in Alaska, and I believe that he was VP of IHI at one point. So we're happy to bring that, go out and get expertise, but also bring that expertise back into our tribal communities.
So we actually have a new development as of Friday. Mass General, Brigham and Women's has an IHS initiative where they send providers out to the Navajo Nation. And so when I started my role, I was like, but why are they not working with the locals? And they didn't know about the locals. And so my work has been to work with Mass General to understand that you have a lot of local natives here, and Boston is very unique in that we have a lot of people from various tribes in the area. And so with the help of Ellen Bell, who leads the initiative with Mass General's IHS, we're now changing the program to Mass General Brigham and Women's Community and outreach to Native Americans in New England in addition to their IHS. And so that will allow them to have physicians that go to Navajo Nation, also work with the local Native tribes here because they already have some level of understanding of what it's like to work with Natives. And so that list is made up of primarily specialists at this moment. And so our next effort will be to get more primary care providers. And so that's a way that we can leverage the resources at Mass General and Brigham and Women's with the local Native tribes here.
Yeah, and Jack, just to piggyback on that, any thing that we can imagine, since we already have an existing agreement with Mass General, if we can imagine it, we can make it work and get it figured out. So just a matter of putting it to print.
Just a quick question. Back to the program where the White House and the IHS and the VA are trying to address Native veteran homelessness, I think is the topic
Right.
there. The programs as starting now, the program now is initiated in the Western United States. So Portland, I believe, California, several other areas in the Western United States. Being here on the East Coast, there's a ton of homelessness, a ton of Native homelessness. Maine, for example, with the Wabanaki Confederacy, Maine homelessness is high for veterans. And then when you look at how many Natives they have up there, they're disappeared. I mean, the state of Maine doesn't see them. The VA system, in my conversations, don't see them. And I'm wondering if the IHS really sees them also. So my question is, how can we begin to take some of, and let's be honest, a lot of people who aren't native imagine natives as being out west. They don't see natives here on the East Coast. They see, like Nashville, IHS has to cover the whole eastern one-third of the United States, whereas in the West, you have these small IHS offices that address certain small areas. So I guess that's a big question, but with many parts. What can IHS do along with the VA and along with the White House to begin to see better Native peoples from various tribal nations on the East Coast, essentially?
Yeah, thank you for that. And I think that data analytics and tracking is an important aspect. One of the reasons for those locations being selected was the magnitude of the issue in terms of numbers impacted. If we were to overlay the urban Indian population, LA is big, Phoenix is number 3, but you don't see New York on that list, right? And New York's number 1. So it's a good point, and I think that we need to make better use of the data available to us and track the right things, and account for those aspects that we're not currently capturing. That being said, this initiative is intended to roll out to other locations over time. This is just their starting point with those 5 geographies.
Do we have any more questions?
I was just curious if there are ways that you have found that have worked particularly well with engaging the veteran and service member community in particular in terms of getting them into care.
Yeah, it's just, as mentioned, it's a struggle. Even for us to find our Native veterans within our system of care, many Native veterans have not applied for their veterans benefits. So they will answer in our intake screening, yes, I'm a veteran, but they haven't gone through that step of obtaining their eligibility through VHA. And so just going back to my history as CEO of the Phoenix Indian Medical Center as an example, only 25% of those who identified as being a veteran were actually enrolled in veteran services. And the reason that was important to us is because we could seek reimbursement from the VA for services to those individuals. So we were working hard to get those other 75% enrolled. But these are only the people who are self-identifying that they're veterans. There likely are many others out there who have also served and have not identified their veteran status for various reasons. So it is something that we need to work on. I think really demonstrating that there are programs out there, and VHA is a partner. I don't ever want to disparage a partner, but there are organizations out there that are running programs that actually work and that are fulfilling the needs of individuals and their families, getting that information widely marketed, advertised, word of mouth, or whatever, that these programs work, I think will help. I welcome my colleagues again. Anything else that you feel that we have done or not done in outreach to Native veterans that we can leverage or do better? It's still a work in progress.
So here, I'm very thankful that I've had a great partnership with the VA here, in particular, John Brown and David Weahkee. They have taught me the intake process, what our Native veterans need to go through, and so we have a direct contact. So as I am out at powwows or outreach, I always have their information with me so that I can share it. That way that we work together to get that individual to have their intake done, or if they need to be in a meeting or whatever it is that they need, we try to remove that hurdle to get them to be able to sign up so they can get their benefits. But it does take time, and you have to find the right people in the VA who's willing to stand with you, and because that process can be long. And so then our community members get really agitated and they don't follow through. So it takes pushing from both sides to really help complete the circle of getting their benefits.
Yeah. I think another aspect, as I think through it, when people see somebody who they know and respect go through treatment, go through a program. Elected tribal leaders, cacique or traditional healer, somebody with prominence in the community, they see them go through a program and exhibit that vulnerability and then come back healed. They're gonna want to follow suit. So I think you see it, you hear it, you live it.
Hi. So I know you discussed the importance of trust in individual providers. I was just wondering how much of a challenge it has been to develop trust in the IHS as representing like a government entity.
Yes, well, significant and ongoing effort. Sorry. So being part of the federal government, it's a dual-edged sword. The great thing about our agency is 70% of our staff, of those 15,000 individuals, are American Indian or Alaska Native themselves. So that mission is very dear to us because we're providing services to our relatives. Many times it's our aunties or nieces or nephews, and you don't want to mess it up. You want to do it right. You want to do it the best you can. So from that regard, we are all striving hard to make it the very best agency possible, but we are still part of the federal government, and we're here to help you, right? So every misstep that we make and gets publicized, it's another blemish on that reputation. And so it starts at home, in my opinion. And when I was the director, I used to try to make this point that we as healthcare professionals are influencers within our own homes. And if we go home from work and we disparage the agency we work with, if we talk negatively about the workplace, people lose trust. They lose trust in their individual providers. They lose trust in their individual hospital and in the agency overall. So if we can be influencers within our own homes and talk about all the great things that are going on and not bring home the workplace drama, that ripples because your family, the family of the physician who's talking to their community members and friends and talking about the positivity. Granted, it doesn't get as much press and airtime, but it's important that those aspects get out. And reputation tarnishment takes a long time to get over. So that is definitely something that we contend with on an ongoing basis.
I think we have time for one last question.
Yeah, kind of jumping off the last question, I'm just curious how well you feel like the IHS is utilized by the Native population. I mean, it might be geographic specific, but is there a percentage you can say has regular medical care, sees a PCP, has an annual physical, has dental care? I'm just curious how it's actually utilized by the population.
Yeah, and I think that varies very much by geography, even by demographic. I would say, in general, young men don't access care. But you have a childbearing aged female with her children. They are very frequently in care. As we age, we're in care more often. But in terms of seeking care from the agency proper versus going outside to another hospital via your private insurance, I think it's a mixed bag. A lot of the tribes have been entering into tribal self-insurance. So they'll use their funding to purchase insurance of their own. And that provides their tribal members with choice, whether they use their internal program or they go out on the economy and purchase it through a different mechanism. So I think there's a lot of variation out there, and I don't know that we track it well. We do strive to be the provider of choice, though, for Indian people.
With that, I'd first, let's give a quick round of applause for Admiral Weahkee. Thank you for this discussion. I know you've shared a lot of great information with us, which will pave the way for a lot more future discussions. And I really do like your expression, if we can think it, we can do it. And I think we're going to do it.
Great.
I'd like to thank Dr. Rose Weahkee for joining us. Appreciate all your comments here in private. We've had dinners together, and the insight you're able to provide is really, really helpful for us. We've got our friends from Native American Lifelines. Thank you for joining us. Arizona State University, you guys are here. Yeah, thank you guys for coming down here. Obviously, our home-based staff, and many thanks to the Massachusetts General Institute for hosting us here today, and obviously the friends from across Mass General listening today. Thank you all for joining us for this great talk, and we look forward to a lot of future action. So thank you all.
Thank you.